We presented some data at BTOG 2020 this week, looking at the use of chemoimmunotherapy as a treatment for the extensive stage small cell lung cancer. Now, this has been shown in a trial called IMpower133, which was presented originally a couple of years ago, and it showed that overall survival has been increased for the first time in 30 years. And this is obviously fantastic. But we now need to think about, if this regimen was available in the UK, what kind of impact would that have on our practice? Because the trial was very specific about a couple of things. First of all, only carboplatin was allowed, not cisplatin. Secondly, no thoracic radiotherapy was allowed. Thirdly, no patients with brain metastases were allowed into the trial. And fourthly, patients were not allowed in who had had steroids as part of their antiemetic regimen. So the question we asked a group of people through the BTOG membership was, would you change your practice? How would this impact on what you do? What we found was that oncologists are happy to be quite flexible. We found that if the drug combination of IMpower133 regimen was available, they'd like to use it. That was about 85% of people. And if we needed to drop the steroids as part of antiemetics, people would do that, very happily do that, in around half of cases to allow this new regimen to be used. Conversely, however, a lot of oncologists would be happy to alter, maybe one might say, the IMpower133 regimen and say, do you know what, I'm going to use those three drugs, the chemotherapy and the immunotherapy, but I am going to give thoracic radiotherapy if I need to, and I am going to give cranial radiotherapy if I need to. So our conclusion from this poster was people are interested in chemoimmunotherapy. That reflects how difficult it's been to find new treatment modalities for small cell lung cancer. And people take a practical approach. They'll amend their protocols and they'll amend the trial protocols to allow it to be given.